pretty honored to have Dr. Kilnani here to speak with us. So Dr. Kilnani is an ex-professor and head department of pulmonary medicine disorders in All India Institute of Medical Sciences in New Delhi. Well, I will now hand over the mic to Dr. Kilnani.
Hi everyone, it's my pleasure to be talking to you from India on the guidelines for the use of procalcitonin for rational use of antibiotics. For that I am thankful to Messrs. Thermo Fisher for giving me this opportunity. So starting my setting the trend for why we are talking about procalcitonin today is because of the antibiotic stewardship program. Now, what is antibiotic stewardship? Is the coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting selection of optimal drugs regimen, dosing, duration of therapy, and routes of administration. The aim is to minimize adverse effects of antibiotics, improve the susceptibility to existing drugs, the optimum resource utilization, and improve the clinical outcome. Now, there's a burning issue that antibiotic resistance is growing and the pipeline for new antibiotics is running dry, especially a problem with MDR, gram-negative bacilli. If we talk about India, we are plagued with gram-negative bacilli which are multi-resistant, and only drug sometime which is of use is colistin or polymyxin. And now we are reaching a stage where sometime we get a report that none of the antibiotics are effective. Now another issue is that how to circumvent this problem. One of the ways to circumvent this problem is to invest in the new antibiotic discovery. And it takes $5 billion US dollars to discover one antibiotics, and 80% time it eventually fails. And majority of the major research companies like Pfizer, Eli Lilly, Sanofi, Bristol Myers have closed their antibiotic research facility due to financial reasons. So what we have to do is the better use of what we already have, and that is what is called antibiotic stewardship. Now, there are certain facts which I would like to highlight, that 30 to 60% of antibiotics prescribed in ICU are either unnecessary or inappropriate or suboptimal. Second thing is time to appropriate antibiotic administration is a major outcome determinant, and only 50% of septic shock patients received effective antimicrobial therapy within 6 hours of documented hypotension. That is a fact. And there are harmful effects of inappropriate antibiotic. These are in the form of development of resistant strain, adverse effects of antibiotics, development of C. difficile infection, development of nosocomial infections, fungal infections, cytopenias, and acute renal failure. And biggest of all is when you overuse the antibiotics, or if your antibiotic use is inappropriate, there is emergence of multi-drug resistant organism, which is a really serious problem. So the now question comes that in that context, why do we need a biomarker? What will be the utility of a biomarker? So the biomarker for antibiotic prescription is actually a need of the hour. And commonest cause of drug use in ICU is antibiotic, leading to enhanced cost and care of adverse effects. And majority of patients, if I talk about India, in Indian ICUs, receive antibiotics irrespective of etiology. The moment the patient is in the ICU or patient is put on ventilator, the intensivist is constrained to start antibiotic whether they are indicated or not. Another issue is that colonization of respiratory tract, skin and GI tract is quite common, leading to undue continuation of antibiotics. One of the studies that we conducted in India revealed that by seventh day, 90% of the respiratory tract and 80% of the GI tract was colonized with bacteria without any evidence of systemic effects. Quite often, the antibiotics, once started, are administered for prolonged periods of time without rational consideration of de escalation. And that leads to overuse of antibiotics, which not only adds to the cost of care but also leads to selective propagation of drug resistant organisms. All these are reasoning for having some biomarker which will tell us whether to start antibiotic, when to de-escalate, when to reduce the dosages or stop the antibiotics so that cost of care can be diminished, the survival can improve, and most importantly, the genesis of resistance goes down. Now, what is de-escalation? The both initiation and de-escalation require clinical judgment and some objective tests. The X-rays are very poor parameters of improvement. Fever, chest examination, clinical examination usually do not help, but they are rather not so precise. The biomarkers have been tried for antibiotic stewardship, for which procalcitonin, and I'll be recited as PCT, is most commonly used for this purpose. There are several randomized trials and meta-analyses which have addressed the issue of use of procalcitonin for antibiotic stewardship, both hospital-acquired as well as community-acquired infection. And therefore, the meeting held to plan the evidence-based guidelines for India and abroad for PCT use for rational use of antibiotics for infection. Now, a word about procalcitonin. Procalcitonin is secreted from thyroid gland and also from endocrine cells of the lung. Normally, it is secreted, but it is detectable in the serum at a very low quantity. However, whenever there is sepsis or inflammation of lung or any part of the body, especially the bacterial infection, the quantity of procalcitonin secreted from not only from thyroid and lung and other organs, the levels increase, and these levels can be measured, and this is a quantitative test which tell us whether to start antibiotics, whether to continue antibiotics, whether your antibiotics are working well, whether your infection is getting controlled. It can discriminate between bacterial and fungal infection. It can discriminate between infectious and non-infectious causes. And COVID time we saw that it can discriminate between viral and bacterial infections also. Now, the less than 0.5 microgram per liter or zero point 0.5 nanograms per milliliter, the value is taken as systemic infection, not likely. When the value is between 0.5 to less than 2 micrograms per liter, it is significant, but it indicates moderate systemic inflammation. Sepsis is likely. When it is between 2 and 10 micrograms per liter, that indicates a severe sepsis. That means there is a severe systemic inflammatory response, what is called as SIRS, most likely due to infection, sepsis, and there is high risk of developing organ dysfunction. Levels of more than 10 micrograms per liter, it is very important systemic inflammatory response almost exclusively due to severe bacterial sepsis or septic shock. So that is why how the levels of procalcitonin are used in clinical practice. Now, potential utility of procalcitonin as can be envisaged. If it is less than zero point 0.1 microgram per liter, you can withhold antibiotics because the infection is most unlikely. If it is zero point 0.1 to 0.25 microgram per liter, then also infection is unlikely. You can withhold antibiotics. Is if it is 0.25 to 0.5 micrograms per liter, that means bacterial infection is likely. You can start or continue antibiotics. If it is more than 0.5 microgram per liter, the bacterial infection is very likely. So the antibiotic should be started. So, are these cutoffs of procalcitonin sacrosanct? How to utilize this biomarker in clinical practice? This is what we are going to discuss today. And to discuss that, a meeting was held uh, under the aegis of Indian Society of Critical Care, logistically supported by Messrs. Thermo Fisher at Hyderabad, where 17 experts gathered and threadbare discussed the evidence of use of procalcitonin for various infections. And this meeting finally, uh, a document was published in the Indian Society of Critical Care Medicine journal called Indian Journal of Critical Care Medicine, which is an indexed journal. And these are guidelines for use of procalcitonin for rational use of antibiotics. So we used the standard gradings for framing these guidelines. That was the evidence was graded as 1, 2, 3, and UPP. One is evidence from more than one good quality and well conducted randomized controlled trials or meta analysis of randomized controlled trial. Two was evidence from at least one RCT of moderate quality or well designed clinical trial without randomization. And the three was evidence from descriptive studies or reports of expert committees from respected authorities or based on the clinical experience. Useful practice points was said when there's no studies, but however, a consensus was reached by the working group based on clinical experience and expertise. The strength of recommendation was A and B. A was when there was a strong recommendation where the experts largely agreed. The weak recommendation was B, where benefits and risks were more closely balanced. So, with that, I will discuss few cases based on which I'll discuss the guidelines. So, case one is a 32 years old male with no comorbidities presented to emergency with fever for 1 week, occasional dry cough. On examination, he was drowsy with a heart rate of 100 per minute. His blood pressure was low, 80 by 60. He had tachypnea with a respiratory rate of 24 breaths per minute. The chest examination was normal. The oxygen saturation was 92% on room air. It started on inotropic support and oxygen supplementation via face mask. COVID RT-PCR was negative. Now, diagnosis is sepsis with septic shock as he had hypotension. Now, the question is, should baseline procalcitonin levels be done in patient with sepsis? That was the question which was discussed, and the the answer was, as baseline PCT is required for guiding antibiotic therapy to look at subsequent increase or decrease in levels, most randomized controlled trials have done a baseline value in suspected sepsis patient and utilized an PCT based algorithm to limit the duration of antibiotics. So, what is the recommendation? The baseline PCT levels may be done in patients with sepsis. The evidence was strong, that is one. The recommendation was moderate, that is B. That means those presenting with severe sepsis should undergo PCT testing for start of the antibiotics. But what is the role? What is the role of PCT in diagnosis of sepsis? That is the question. So the PCT can diagnose sepsis only with moderate accuracy. The cutoff values for diagnosis sepsis are not well defined and need further clarification. So the recommendation is that PCT alone should not be used for the diagnosis of sepsis. That is 1A. That means high quality evidence and strong recommendation, and we suggest that PCT be used to differentiate culture negative sepsis from non sepsis. That is 2B, moderate quality evidence and weaker recommendation. So therefore, PCT should be done at the beginning of the suspected sepsis, but it cannot be used as a single parameter for deciding whether to start antibiotic or not to start antibiotic. So the blood and sputum culture was sent for this patient. Patient was started on ceftriax on azithromycin. Supportive treatment was continued and patient wean of inotropes. So patient was improving. Now the question is, should PCT be used for antibiotic de-escalation? Number one. Second is, what level of PCT should be used for discontinuing antibiotics in sepsis? And how often should PCT level be repeated after baseline value? So the answer is that should PCT be done for discontinuation of antibiotics? PCT treatment reduces duration of antibiotic therapy and duration of hospital stay in adult critically ill patients with sepsis without any increase in mortality. Uh, and PCT based protocols are associated with significant overall hospitalization and low cost. And recommendation was that PCT levels can be used to support discontinuation or de-escalation of antibiotic patients with sepsis. That was 2A. So it was clear from the discussion that if we use a PCT in patients with sepsis, it reduces the duration of antibiotics, it reduces the quantum of use of antibiotics, it reduces the duration of hospital stay. However, it does not change the mortality. Now the questions come, how often PCT level be repeated after baseline value? Now this was a, should it be done every 24 hours, 48 hours or 72 hours? That was the question. There is no evidence to suggest optimal frequency of PCT testing. That is the evidence. So the recommendation and PCT level may be repeated every 72 hours or earlier if clinically indicated. That is 3B. That means very low quality evidence and weak recommendation. So next question comes, what level of PCT should be used for de-escalation or discontinuation of antibiotics in sepsis? Now, the recommendation is there is no evidence to suggest the optimal duration or frequency of PCT testing. In various studies, the PCT has been tested every 24 to 72 hours. And however, PCT levels of less than 0.5 nanograms per ml or drop of 80% from the baseline be used along with clinical judgment for antibiotic de-escalation. It is 3A. That means low quality evidence but strong recommendation by the group that PCT should be used for de-escalation of antibiotics. Now, one should understand that sepsis is caused by several microorganisms. Are there any infections which PCT is not, for which the PCT is not an effective biomarker? Unless we understand that, we cannot use this parameter. So the statement is that PCT is inconsistently raised in infection with Legionella, Mycoplasma, and Chlamydia, and it may be false negative in localized infections like tonsillitis, sinusitis, cystitis, uncomplicated soft tissue infection, abscesses, or empyema. it may be raised in non-bacterial infections also where antibiotics are not required, like scrub typhus and malaria, and with variable in candidal infection, and maybe negative in aspergillus and mucormycosis. Therefore, the limitation of PCT for antibiotics should also be used. So therefore, the recommendation was that physicians should be aware of infections where PCT is not a reliable marker, and which I have already narrated. So going to this was about sepsis. So if I could summarize it for sepsis, PCT is a good marker. It should be used initially. It should not be used for decision making for starting the antibiotic. However, if the values are say more than 10 or more than 2, the bacterial infection is most likely. It is very useful for de-escalation of antibiotics, and value of less than zero point 0.5 or 80% reduction from the previous from the baseline is taken as a parameter for de-escalation of antibiotics, which leads to reduction in the hospital stay, duration of antibiotics, and cost without affecting the mortality. The second case is a 45 years old male with no comorbidities presented to emergency with fever, cough, and purulent expectoration for 1 week. He was hemodynamically stable with SpO2 of 90% on room air, started on oxygen via face mask, cultures were sent, shifted to the ICU. This was the X-ray. As you can see, he has got a consolidation of the left lung. So the clinical diagnosis, community-acquired pneumonia in a apparently healthy 45 years old male. I'll recite it as CAP. Now, attending physician started on amoxiclav and azithromycin as per the guideline, and PCT was 4.5 nanograms per ml. Now, should baseline PCT value in this case be used to decide antibiotic initiation? That was a question which was discussed. So, the statement was that baseline PCT level has not been consistently shown to reduce antibiotic exposure in CAP. So, therefore, most guidelines recommend against withholding antibiotics in LRTI or CAP based on the baseline PCT. And the recommendation was baseline PCT levels alone should not be used to withhold empiric antibiotic therapy in patients with LRTI and community-acquired pneumonia. That is 1A. That means high-quality evidence with a strong recommendation. Based on clinical judgment, prompt initiation of optimal empiric antibiotic therapy is recommended in patients with LRTI, including community-acquired pneumonia. The question is then, what is the utility of PCT in optimizing uh, antibiotic use in lower respiratory tract infection and community-acquired pneumonia? So, in patients with SCAB, the baseline PCT alone has limited utility in clinical decision making regarding the initiation of antibiotics. In clinical trials, PCT measurements have been performed at randomization or emergency hospital admission. The recommendation is that PCT not to be routinely measured for initiation of antibiotics. It should be obtained in severe CAP for subsequent de-escalation. That is 2A. If indicated, baseline PCT should be preferably measured at admission. That is 3A. That is, group strongly felt that in severe CAP, the initial PCT should be done for further de-escalation of antibiotics. Now the question is, can PCT level be used to differentiate between viral and bacterial etiology? This issue was very important during COVID times because COVID pneumonia was so common. This is a viral pneumonia. And that actually told us a lot of things about utility of PCT. The statement is that higher PCT levels are strongly associated with typical bacterial infection, as I have said, and baseline PCT levels have varied sensitivity in differentiating between bacterial and viral cap. There are currently no established threshold values for PCT to discriminate between viral and bacterial pneumonia. However, the statement was PCT alone should not be used to differentiate between bacterial and viral etiology in patients with CAP. That is 1A. Now, going further, so this patient improved over last 5 days. Culture became negative. Oral route of administration antibiotic was initiated. Should serum PCT be used to determine duration of antibiotic therapy? That is de-escalation. That was the question. So day 6 of hospitalization admission. Yeah. So the recommendation is that same, that for de-escalation of antibiotic, the PCT can be used, and the parameters are same, that is less than zero point 0.5 nanogram per ml or 80% reduction in uh, from the baseline PCT level should be used for de-escalation of antibiotics. That is the recommendation. So this case, on day 6 of hospitalization, he was improving, this patient, but he developed new onset fever. The ABG showed respiratory alkalosis with hypoxemia with PF ratio of 170, needed oxygen supplementation via high flow nasal cannula, and serum procalcitonin was 1.2 nanograms per ml. Now, what has happened that he has developed hospital acquired pneumonia, and that is we are going to discuss further. Now, patient was initiated on piperacillin tazobactam and levofloxacin with local antibiogram. Supportive treatment continued. Patient showed clinical improvement within 2 days. Now, in this case, should it have been wise to use PCT level to decide antibiotic initiation? Second question is, how often should PCT be repeated after a baseline in hospital acquired and ventilator associated pneumonia? So, should PCT level be used to decide antibiotic initiation for HAP and VAP? That is a question. So, PCT alone has limited utility, same as for community acquired pneumonia in diagnosing or predicting outcome of hospital acquired or ventilatory associated pneumonia. Baseline PCT values may be used to aid clinical parameters for decision making. That is one. So, in the VAP and HAP, the antibiotic should be started irrespective of PCT uh, levels, and they alone should not be used. However, if the PCT is more than 5, more than 10, then bacterial infection is most likely. Then, how often it should be repeated? The serial PCT levels have been used in antibiotic de-escalation and antibiotic stewardship studies, and most studies have measured PCT daily in critically ill and every 48 to 72 hours in a stable patient. Most studies of VAP have done daily PCTs. So, the statement recommendation is that serial PCT level measurement, preferably 48 hours, every 48 hours, should be used for antibiotic de-escalation. That is useful practice point. Now, the sputum culture grew Pseudomonas, this patient, which was sensitive to piperacillin tazobactam, which was started. Patient improved clinically over next week. Treating team repeated PCT on day 8 of hospital acquired pneumonia. The PCT was 0 0.4 nanogram per ml. Should PCT be used for de-escalation of antibiotics in this case? And what cutoff value of PCT should be used to consider de-escalation? That's an important question. So the answer is, through PCT-based antibiotic de-escalation has been associated with decreased antibiotic exposure and better outcome without any significant increase in treatment failure. Whenever you are reducing the antibiotics or stopping the antibiotic, there is always a fear of flare of infection, and these are life-threatening situations. Therefore, it has been proven by studies that when you use PCT for reducing de-escalation of antibiotics, it does not lead to treatment failure. So the recommendation was that PCT should be used as a part of antibiotic stewardship program for antibiotic de-escalation in patients with VAP on antibiotic beyond 7 days. So whenever there is prolonged treatment, which is usual thing in VAP that and HAP that we do 14 to 21 days is usual. So PCTs has immense value in de-escalation and stopping the antibiotic. This is one A, that is high quality evidence and strong recommendation. So what cutoff value you take? It's the same for sepsis as for CAP. A cutoff of 0.5 or a decline of 80 to 90% of baseline PCT is taken as a parameter of de-escalation. So recommendation is PCT of less than 0.5 nanograms or a decline of 80% from baseline with clinical criteria should be used for de-escalation in WEP and HEP. Decline of 80% from baseline and clinical criteria can be used for de-escalation, and it does not lead to failure of therapy. It reduces the duration of ICU stay and also the cost of care because of lesser use of antibiotics. So this is the last case. Case 3, 43 years old male, chronic alcoholic, diagnosed chronic liver disease with portal hypertension, refractory ascites. Fever, diffuse abdominal pain, vomiting and altered sensorium. Blood pressure was on the lower side, 90 by 50. Ascitic fluid had polymorphonuclear leukocytes more than 650 per cubic millimeter. Gram stain was positive. A diagnosis of chronic liver disease with spontaneous bacterial peritonitis with septic shock was made. The question is, what is the utility of PCT in infections among patients with SBP, that is spontaneous bacterial peritonitis? Uh, the answer is in this statement that PCT has been used to diagnose SBP with various sensitivity and specificity, and it is used for prediction of risk of septic shock and mortality among patients with secondary peritonitis. So if the PCT levels are high, the patient is more likely to go in shock. So the recommendation is that PCT is useful but should not be used alone for diagnosis of SBP, and it should be considered for diagnosis of SBP in combination with clinical features, and it can be used for risk stratification among patients with secondary peritonitis. We recommend use of PCT for guiding antibiotic therapy among patients with severe secondary peritonitis. So, if I could summarize what I have presented to you, that PCT is amazingly useful in intensive care unit for reducing the antibiotics for de-escalation. Although some studies have shown mortality benefit also, but majority of time the clinical parameters should be used, and out of all the biomarker which has been used in the history of medicine, the PCT has been most useful in grading the severity of infection, grading the severity of bacterial infection, reducing the antibiotic use, de-escalation leading to overall improvement, and I think it is a great future. In India, if I could talk about, all the ICUs are using procalcitonin for the routine for clinical use, although it is little expensive. But given the fact that overall it reduces the antibiotic use and leads to overall improvement, and some studies have also shown the mortality benefit, this biomarker seems to have a great future in the clinical use in our ICUs all over the country. I have a pleasant duty of thanking Indian Society of Critical Care Medicine for promoting this academic activity, and also the Thermo Fisher Scientific for providing logistic support to frame this guideline. So thank you very much. With this, hand over the microphone to the moderator. Thank you.
Okay, thank you so much, Dr. Kirdani. Thanks for the wonderful talk. All right, now we are in the Q&A time. We will also ask the audience to leave their questions on the chat box. I have a few questions first for you. So first of all, we would like to know whether in your hospital, do you have an antimicrobial stewardship program and team? And do they use procalcitonin to guide antibiotic use?
Yes, we have an antimicrobial stewardship program, but it may not be followed as it is followed in the Western countries. But we have a program, we have a hospital infection control committee which always monitors it. But as far as the PCT procalcitonin use is concerned, we use it all the time. As I've said, but we use it only in the intensive care unit for seriously ill patient. All the patients, whether it is the sepsis of unknown origin, whether it's a community acquired pneumonia, whether it's, even we are using it for pancreatitis, which is acute pancreatitis. The patient is in the ICU, and which actually I didn't get a chance to cover. In pancreatitis, the secondary infections are exceedingly common, and it is recommended not to use antibiotics in the initial stages. But we always monitor them clinically and also with the PCT to find out whether the patient is having bacterial infection. So we are using it very, very regularly, and we are finding it useful. Thank you.
Well, thank you for the answer. It seems like your ICU setting doesn't need stewardship program at all. You are practicing stewardship program very well with procalcitonin. Okay, so one other question is, do you have oncology patients?
We have oncology patients. Our hospital is not dedicated to oncology, but a small percentage of patients. We have an oncology unit, and our ICU is an open ICU where oncology patients are also getting admitted.
Okay, so in these oncology patients, procalcitonin is also applied to them as well?
Yes, it is applied to them. And as for I had only 30 minutes, so I didn't cover patients who are immunocompromised because of oncology, chemotherapy and radiotherapy. Now, as far as the PCT is concerned, it is actually quite specific for bacterial infection. And oncology patients have, lots of viral infection and lot of fungal infection. So suppose an oncology patient who has received chemotherapy has got fever, and if his PCT is high, we know that the bacterial infection is there, and we put all our money on giving antibiotics. However, as I have said partly in my presentation, in patients with fungal infections like mucormycosis or aspergillosis, the PCT is not raised. Even with Candida, the chances that PCT would be raised will not be very high. So therefore, it helps us in discriminating bacterial infection from fungal infection and other viral infections for that matter. So therefore, it's a very good tool for differentiating viral infections and fungal infection from bacterial infection. But I want to say that the differentiation is not absolute. As the more studies will be conducted, we will have more clarity on that. But if I could give one line that in oncology patient, the PCT is very useful.
Thank you so much for your insights. Yeah, we do use PCT in oncology patients, in ICU patients, and hepatitis patients as well in our institution. Okay, one last question. Can you tell us what kind of PCT cutoff that you use for your end-stage renal patients, patients with hemodialysis and so on?
I don't think there's a lot of difference between using patients who are chronic kidney disease or hemodialysis patients. Actually, this is a very important group, and incidentally, my hospital has a dedicated nephrology unit with a large number of patients on dialysis and also kidney transplant patients. So these patients, they frequently come with infections, and fungal infections are extremely common. But the cutoff value that I take is zero point 0.5, the same as
I
I
see.
use it for other infections also. But uh, CKD patients, because of their other conditions, usually the PCT levels should be always be correlated with other clinical parameters, and one should be used a little more careful than other apparently healthy persons. Thank you.
Thank you so much, Dr. Kilnani. Thank you.
Thank you.
Thank you for coming on board to join us in this talk today. For the next talk in August, we will have Dr. Akihiro Ito from the Department of Respiratory Medicine from Kurashiki Central Hospital, Japan. He will be giving us a talk in deciding or teaching us to do an algorithm for PCT-guided antimicrobial therapy, a consensus statement by Japanese expert in August. Thank you. Please join us again in August. Bye-bye.